lipoproteins and lipids. All right. We went through during the regular chemistry, we talked about saturated versus unsaturated, and you guys can review this yourself. I'm not going to go back over this, and most of us who are at all health conscious know about those particular things. Now, lipids, when we measure lipids, or when we look at lipids in the laboratory, we are measuring triglycerides, which are glycerol with 3 fatty acids, and the reagent that we use is lipase. In your body, you also have pancreatic lipase that breaks down triglycerides into its fatty acids and glycerol, so that you can utilize those fatty acids for energy. Now, triglycerides, you can have endogenous or exogenous. 95% of the fats that we intake are triglycerides. They are transported as chylomicrons. Now, remember, let's jump ahead. What does a person's serum look like if they are in a non-fasting state? Say they just went and had a Big Mac. So it's opaque. So the chylomicrons that circulate immediately have lots of triglycerides, and they are opaque looking. It's not so much that it's cholesterol, it's the triglycerides. Then over a period of time, they are cleared from your system by your liver to be utilized for energy. Now, cholesterol is used for a lot of things, and it is also important as a base for your hormones. So you can't go entirely without cholesterol because it's very important in hormone structure. All right, here's the structure of cholesterol. It's very flat looking, and we know by autopsy on people that most of the plaque that we see inside an artery is cholesterol. Because it is so flat, it flattens out, and then it starts layering inside that plaque to eventually cause problems. You maybe get a clot formation because it makes it very ragged. Inflammation starts to occur, and that's where you can have an MI if you have too much cholesterol. All right, now what is a lipoprotein? That is what carries around these lipid particles, because remember, lipids are not soluble in water. You need something to make it more soluble. So think of a lipoprotein as a little car that drives these things around to get them from place to place. So HDL is associated with different percentages of cholesterol, triglycerides, as then the bigger particle, or your chylomicron, you can see is a much larger particle, and it has more triglycerides in it. All right, so we know that those chylomicrons make the sample appear more opaque, and they can actually float, and it is because of their size and their density. Now, when we do an electrophoresis on lipids, we will look at them, and HDL is what they call the alpha, so it is the alpha lipoprotein, or the fastest. It actually goes with the alpha area of a protein electrophoresis. That's why they call it that. So if you remember protein electrophoresis, you should also remember lipid electrophoresis by the names of the constituents here. So it's followed by then VLDL, which is called pre-beta. Go back to your protein electrophoresis. LDL then it migrates with the beta area, and then you have your chylomicrons. Now, they're the largest. They're associated with lots of exogenous triglycerides. The apolipoproteins that go with them are C and B48. I don't think you're going to have to know this for the test, so I would not put this at the top of your list to remember or to study. All right. Now, clearance time about 6 hours after a meal. One of the questions they always ask is which test is most affected by a non-fasting state. So you know, triglycerides. Then we go on VLDL, 50 to 65%. LDL, now LDL is known as the bad cholesterol. Why is that? Because it's responsible for transport of your cholesterol to your tissues. All right, where HDL is responsible for picking up that cholesterol from your tissues, taking it back to your liver. So as LDL values increase, you have increased coronary heart disease risk. So LDL is a definite risk factor. HDL, on the other hand, is a negative risk factor, meaning the more you have, the less your coronary heart disease. Now, the old method of cholesterol methodology is the Lieberman-Burkhart reaction, which is no longer used because it used very strong acids. The reagent that we use now is an enzyme, cholesterol esterase, as is most of the reagents that we use on the instrument. Many of them now are enzymes used as reagents. Triglycerides, we use lipase to break it down into its fatty acids and glycerol. Now, HDL, we more often do a direct method now, but you can actually do a method where you can precipitate out other lipids and then measure the HDL that is left. This is an older method. Unfortunately, if you have very high triglyceride levels, you cannot do this method. Another thing is you cannot do or use the LDL measurement. Now, is this an equation that you may have to know? Yes. Add this to your card of equations to know your LDL calculated value. Many labs now are doing LDL direct measurements. The reason they are doing that is because Medicare does not pay for a calculated test. So you have to measure it directly in order to be paid for it. Stool fat, we talked about this before. We know that in malabsorption you have increased amounts. And these are all of the different prevention methodologies, and I'm not going to go through all of this stuff. You guys can go through it and know that what goes along with high cholesterol, high triglycerides, most often are coronary heart disease. Now, up to this point, triglycerides have not been implicated. But I think they're looking a little bit more closely at triglycerides. Now, Hypolipoproteinemia is probably one of the few genetic types of diseases where you have no HDL. This, you will get high coronary heart disease at very young ages, called Tangier's disease. You also have your lipid metabolism diseases, your Tay-Sachs, your Fabry's. All of those have to do with some sort of lipid storage or lipid enzymes that accumulate, can cause retardation and other things, depending on what kind of disease it is. All right, let's jump right into carbohydrates. And carbohydrates measurements in the lab are usually of the, we measure beta-D glucose. We know most of this. We know it is a hexose that we're measuring. The most abundant is D-glucose, where you have also D-fructose, D-galactose. Recently, have you guys heard on the news about the high fructose or high fructose corn syrup? This has been making a big play on the news with obesity, that fructose in that high levels of those corn syrups are being implicated in obesity because it's in many of the sugary drinks that kids drink. And I guess it's metabolized a little bit differently and has effects on people differently. People don't realize the amount of calories that they ingest of this particular type. So I know in some of the drinks we have in here, yes, high fructose corn syrup. So one of the other things that they also talked about was sodium. If you guys have turned on the news at any evening, big things were sodium and this high fructose corn syrup. And they're saying some of these processed foods in one serving have all of the sodium for one day. So really you need to look at some of these processed foods and say, wait a minute, I shouldn't be eating all or intaking this amount of sodium or this amount of sugar, because that is my daily requirement in one serving. I guess it's different if you only eat once a day. All right, we know fructose, galactose, they are monosaccharides. What is a reducing sugar? All right, and what is the test that we use to do reducing sugar? And that is the Kinetics. All right, which one is a reducing sugar? Maltose is a reducing sugar. It has 2 beta-D glucoses. Lactose is a reducing sugar. It has glucose and galactose. Sucrose is not a reducing sugar. All right, it doesn't have any free aldehydes or ketose groups, so if you took table sugar, it would not react with Kinetics because it's not a reducing sugar. Starches, we know, are long chains of many carbohydrates. We have different types of starches, glycogen being the storage starch in most animals. And in man, we have glycogen. We know how things are digested, how they're saved. Some of the terms that we should remember: glycolysis, conversion of glucose to pyruvate or lactate; glucogenesis, process of glycogen formation; glucogenolysis, breakdown of glycogen; gluconeogenesis is the formation of glucose from non-carbohydrate sources. And remember, the reason that some of these things happen is maybe in a long fasting state. You need to start breaking down other substances to give you energy. The Atkins diet, yes. The most, and remember, your body needs to keep your glucose level at a set rate because it needs to feed your brain. If your brain goes below a certain level, you will become unconscious. All right, and we know about what happens in a short fast. You go through glycogenolysis. In a long fast, then it's gluconeogenesis. Some of the fake sugars, you can go back and look over that, but I don't think you're going to have any questions about that. Now let's talk about some of the hormones that affect glucose: insulin, glucagon, epinephrine, cortisol, and growth hormones. Insulin, we know, is the only hormone that will reduce your actual glucose circulation, reduces it. It is secreted from the beta cells in the islet of Langerhans in your pancreas. It is secreted or excreted in response to high levels of glucose. What does insulin do? It attaches to that cell so that glucose can be taken into the cell. Glucagon, on the other hand, is responsible for increasing the blood sugar. So now all of these other hormones are what we call antagonists to insulin, meaning that they do the exact opposite of insulin. So it's secreted by the alpha cells, not the beta cells, in the islet of Langerhans. And when your blood sugar goes too low, then it is secreted or stimulated to increase your blood sugar. And we know what happens in a high blood sugar stimulates your pancreas to stimulate insulin. Then blood sugar levels come to normal values in your circulation, and glucagon works the exact opposite. Now, epinephrine or adrenaline is also an antagonist to insulin, and what it does is it is secreted by your adrenal medulla. It is excreted in response to physical, emotional stress. And all of us have had this happen to you before. If you measure somebody's glucose levels directly after something like this occurs, their glucose levels go up. And that is so that you have energy, excess energy, to help with that stressful situation. And they say that epinephrine adrenaline goes back to the times when we used to have to run from wild animals. If we went out, we were the hunter-gatherer, and you go to kill an animal so that you can eat it, and if it turns and chases you, you had to have that adrenaline or epinephrine rush in order to get you out of that situation. All right? Now, growth hormone. Growth hormone is also called somatotrophin, antagonistic to insulin. What it does, it inhibits glucose uptake by the tissues, and what it gives you is more circulating glucose for growth and development. Thyroxine, T4, ACTH, and cortisol are also all antagonists to insulin. And the outcome, remember, is to increase your blood sugar so that you have more available for whatever stressful process or happens to be going on. Now, we know hyperglycemia is in several categories of diabetes mellitus. Type 1 is insulin dependent. Usually you see this in a younger group. Type 2, usually you see in an older group. Type 1, remember, is a total decrease in the amount of insulin produced. Many of those people, it can be because they have damaged pancreases. Type 2 is your cells become resistant. For whatever reason, either you've gained weight, diet, sedentary lifestyle, whatever it is, genetics play a role in that. Your cells become more resistant. Now, there's other types such as gestational and genetic types of defects, but 1 and 2 and usually gestational are the 3 most common types. So we know can be genetic. It is on the chromosome, type 1. Polyuria, polydipsia, hyperglycemia, glucosuria, polyphagia. Those might all appear on today's test, right? Yes, ma'am. What hormone increases your blood sugar when you're pregnant? I don't know. Beta-HCG? Now, remember, there's a lot of hormones that can affect your blood sugar, so that if you are pregnant, you do have, you may have normally more circulating glucose. But I don't know if it keeps it at a real high level for any period of time. cortisol? Cortisol is very important for, is it an estrogen, a luteinizing hormone? So it does say in the cartoon book. All right, we'll come back to it. Type 2, once again, is a milder form, relative deficiency of insulin. We are seeing type 2 now in younger people and even in children because of their diet. Gestational occurs during pregnancy and many times goes away when the child is born. But what they say is that particular type of diabetes can go on to maybe later on in life, this person will have a higher probability of getting type 2 diabetes. Now, the new acronyms that they use are impaired fasting glucose, IFG, that is characterized by plasma glucose levels following an 8-hour fast that are greater than normal, but you can't say that they are elevated enough for diabetes mellitus. So if you are in the IFG or impaired fasting glucose category, you can be put on diet and exercise. And impaired glucose tolerance is, oh, I'm not familiar with that, human placental lactogen. It increases glucose, yeah, and I would think for the baby purposes, yeah, but it should not elevate you to the level that you're going to have impaired glucose tolerance. All right, that is the big key, that you can have elevated glucose levels, but not to where you're not utilizing the glucose effectively. Your cells become resistant, right? And when that occurs, then you are going to have to take insulin. Usually gestational diabetics, many of them can either do diet, exercise, or they are put on insulin during their pregnancies. Now, here is what the American Diabetes Association says. You must be less than 100 to be considered normal, fasting. If you are above norm 100 fasting, you are in the pre-diabetes area, up to 126. If you go greater than or equal to 126 fasting, you are a diabetic. That's what they're saying. Now, if you do a tolerance, what they're saying is that you should never go above 140, because greater than or equal to 140 at any time during your tolerance means that you are a pre-diabetic. So you want to stay below 200 and in between 140 and 200. That is considered pre-diabetes. Now remember, when you do a glucose tolerance, you want to return to normal within 2 hours. So what the ADA recommends, that anybody older than 45 should have a measurement of fasting glucose every 3 years, unless you are diagnosed with any of the previous conditions, impaired glucose tolerance, etc. So to diagnose diabetes, you need a random blood sugar concentration of greater than or equal to 200, or a fasting plasma glucose greater than or equal to 126, or during an oral glucose tolerance, a 2-hour after the oral glucose tolerant load greater than or equal to 200. So these are what the American Diabetes Association has put forth for the criteria to diagnose diabetes. All right, and remember how to give a tolerance. Normal tolerance, you want to make sure that your patient is less than 140 milligrams per DL. preferably in the normal range. Some labs have different cutoffs than other labs for actually doing a tolerance. But then within the first 30 minutes, draw their fasting, make sure that it is okay, then give them the glucola, have them drink that quickly, and start timing the test once they've finished drinking the glucola. That's when it starts. And then 30 minutes after, draw. 1 hour after the beginning, so it's 30 minutes after that first draw. So how many times do you draw the patient in the first hour? 3 times, right? Fasting, half hour, and 1 hour. So technically you're drawing them in the first hour. You should be drawing them 3 times. Here's an example of normal. Notice that normal hits about the 140 level and comes back to normal within 120 minutes, 2 hours. Notice that the diabetic, they start higher, they go higher, they do not come back to normal within the 2-hour limit. Glycated hemoglobin, or hemoglobin A1C, what is that used for? Determining long-term glucose or insulin therapy. So normal is anywhere from 5 to 6%. If you are over that into the 7.58%, then that's a high amount of glycated hemoglobin. And remember, this test is based on the fact that each cell lives 120 days, and that binding of glucose is irreversible on the C-terminal. So therefore, hemoglobin A1C. So you can determine about a 2-month compliance. So you can actually draw your patient's sample and see how well they were in compliance over that 2-month period. Fructosamine will measure glycated albumin. That will determine their glycemic control over a 3-week period. Now, insulin level, you can actually do an insulin level. Many times with high amounts of insulin, somebody having actual hypoglycemia, what is happening is they could have an islet cell tumor, therefore they have more insulin being secreted. C-peptide is an important test to do because you can see if that insulin is coming from exogenous areas, meaning that commercial insulin has no C-peptide. So if somebody actually gave a person exogenous insulin, you can test the C-peptide level. This is kind of a forensic type of test to see, is the patient giving themselves too much insulin, or do they have insulin that they're using and not telling the physician about? Or is somebody giving their patient too much of this insulin? Now, glucose analytical procedures, remember, you will decrease in glucose about 12% an hour at room temperature. Therefore, you want to draw an appropriate tube. The gray top tube, sodium fluoride, is used to prevent glycolysis. Spinal fluid should be tested immediately to determine its glucose level. So you could have a test question that it talks about transport of glucose, maybe from an outpatient facility. And it might say, if you were, unrefrigerated blood is going from an outpatient facility and being tested in your laboratory for glucose, what would be the best tube or the best way to transport that? Well, it could be drawn with a gray top tube to prevent glycolysis in that particular instance. Okay. Now, the methods that are used now are almost entirely enzymatic. We don't use very many chemical methods other than the Kinetics tablet. That is a chemical test. and that is considered Benedict's test. Let me go back to this too. The dipstick method for glucose testing is glucose oxidase. So remember, when you get a positive on a dipstick, it is glucose only. You would not normally do a Benedict's or Kinetics on a specimen that was negative, except with a baby, because a baby could have galactose. So think about it, they would not have the dipstick positive, but their Kinetics will be positive. Another reason too you can have a positive Kinetics with a negative dipstick is maybe a new mother who's nursing. She's got lactose being absorbed back into her system, but she would not have a dipstick that would be positive, so you would not go back and do Kinetics anyways. Now, vitamin C, uric acid, creatinine, they all interfere and all react as well with Kinetics, so you will get a positive test. False negative from vitamin C and too many urates, and false positive if you use anything like bleach, hydrogen peroxide contamination. This is with your glucose oxidase test strips, not with Kinetics. All right. Now your ketones. What are ketones? You have the ketone bodies, which are 20% acetoacetic acid, 78% beta-hydroxybutyric acid, and 2% acetone. What we normally measure in urine and in blood is the acetoacetic acid. So you can see it is half the amount, or a very small amount, compared to beta-hydroxybutyric acid. Nitroprusside is used for both methods, serum and or urine, so you can use the same tablet, drop a serum on it to see if this patient is in ketoacidosis. Microalbumin testing is done in a different method than regular albumin testing, because you want to test for neuropathy from low levels of albumin being excreted, usually in diabetics, because you can treat the patient's blood sugar with insulin, treat it more appropriately to prevent kidney failure over a long period of time. Now, the ADA recommends that the patient be screened annually for 30 to 300 milligrams per day using random or 24-hour urine albumins. So that's what the American Diabetes Association says to do on a yearly basis. And as renal disease progresses, you will see up to 550 milligrams per day increase, and that you can detect on a regular urine dipstick. And at that point in time, usually you already have renal damage that is too far to actually go back. And remember, when we talked about urinalysis, the #1 hallmark of renal disease is protein. So once you start seeing protein in the urine on a routine basis, you already have renal damage. That goes for somebody with diabetes, somebody with high blood pressure, etc. Right, you got to go over that 100. Right, and this says per day, but you have to go per excretion. Microalbumin, remember, measures lower levels. So if a diabetic comes in with low levels, maybe 30, they are getting a baseline. And then the next one they have, if it increases or shows increases, then they may say, okay, let's adjust your insulin. But they are doing that at low levels, because it has been shown that it even at low levels, you can have renal problems with that group of patients. Right, for a normal person, right, and you're not going to see that on the dipstick on a normal base in a normal basis. Okay. All right, let's start with enzymes. We know that enzymes aren't changed. They enhance a reaction. So you can see that the enzyme will bind to the substrate to give you the enzyme substrate complex. The enzyme is unchanged, and then you will have a product that is formed. All right, so we know that enzymes, how they work. We just need to know a few basics about, okay, how does an enzyme work, and what do we need to remember for the certification test? What do we need to remember? All right, we know that enzyme levels are intracellular. When we start seeing high levels, it means you have cellular damage, high cell turnover. Now, what happens is if you have normal enzyme or normal cellular death, you have normal enzymes in your circulation, and then those enzymes are excreted usually through the urinary system, and the level stays pretty accurate, or it stays the same. All right. Now, one thing that is very important in this slide is that truly there is no tissue-specific enzyme, but what we are going to do is use each of these enzymes and say that, well, it is more predominant in this particular organ system, so we are going to assume that it is coming from that particular organ. But remember, you want to use a combination of enzymes along with some other chemical tests to determine whether a particular organ is being affected. All right, and an isoenzyme is an enzyme that is a little bit more specific. It is usually a peptide of that enzyme, but isoenzymes such as the CK isoenzymes make CPK more specific for cardiac muscle, for instance, because the MB fraction of that isoenzyme is coming from the cardiac muscle. Now, measuring enzymes, we measure the rate. Unlike Beer's law, we measure the rate of the chemical reaction. So, what I want to do is talk about, I think I have here's my favorite chart. When you add your patient's serum to your substrate, what happens here? The enzyme and the substrate bind. Remember, they're coming to an equilibrium. When you get up here to zero order kinetics, then you start measuring the rate of this reaction. And remember, the rate is the amount of product being formed from that enzyme. Now remember, what is the rate limiting factor here? You want to make the enzyme the rate limiting factor, right? Because you want to know how much enzyme is present. So you want to do an overabundance of substrate. What happens if, and I know all of you have seen this now working in chemistry, if you see a very low enzyme level, for instance, a 0 CPK, and the instrument reports out low assay range, what's happening? Remember, what's happening right here? You're in first order kinetics. As it goes up, it's continuing to go up. It looks like a straight line. What will a straight line up measure? 0. Okay, there is no rate. It's not changing over this time. It can't measure a rate because the rate is going straight up. It's happening so quickly that it can't measure it. And what is the rate limiting factor? The substrate at that point. So what do you need to do? Dilute the sample and rerun it. Now, it is always important to say, well, that patient ran low before. Okay, maybe on the previous, but make sure that it is not a very high value instead of a very low value. There are some people that do have very low CPK values in circulation, but most of the time it is because it is greatly elevated. All right, so this can go with any of the enzyme measurements, because remember how you're measuring these enzymes. You want to make sure that your patient's serum enzyme is always going to be the rate limiting factor, not your substrate. And that's why your manufacturer puts in there huge amounts of substrate so that it never will run out of substrate. So if you have a lot of enzyme, then it can convert to product at a fast rate. That fast rate then will convert into a high number when you report out your enzyme results. What things factor in when you're measuring enzymes? Things like pH, temperature. So what temperature should you measure enzymes? 37. So usually they're measured at body temperature. What about pH? You want to measure it at the pH that enzyme normally operates in vivo. Now remember, we do have alkaline phosphatase that measures at an alkaline area. We also have acid phosphatase. So in those particular instances, you know that the reagent may be more alkaline or more acidic in order to give the enzyme its production or its effect, so you can see the rate more effectively. All right, different types of measurement. You can do endpoint, multi-point, continuous point. The most common method now is continuous point. Adds the stuff to the cuvette, then it incubates it for maybe 1 minute while it's doing something else. Then it comes back to that cuvette and the spectrophotometer starts measuring. Because as it's measuring, remember, the absorption level may be going up if you're measuring hydrogen, for instance. So then what it does is it measures that rate of absorption and then gives you, converts it to your enzymatic value. All right, let's talk about each enzyme. CPK, we know, comes from all skeletal muscle. We know this is what it does. It converts ATP back down to ADP for energy. Highest amounts are found in your skeletal muscle, your heart, and your brain. All right, we can use this diagnostically, and many times we look at CPK for a couple reasons. One is an acute indicator of acute MI. Another thing is muscular dystrophy of the Duchenne type. You can have high levels of CPK with high levels of MB. So if you see a small child with this, think of Duchenne's muscular dystrophy, not an MI. Also remember that values differ per muscle mass. Men have more muscle mass, therefore higher CPK levels than women who are very slight and have small musculature. All right, your isoenzymes, you want to look at what is the fastest for CPK. BB is the most anodic, moves to the positive anode quicker. MB will fall right in the middle. This one shows you macro, which we never measured. And MM is the normal. So if you had a normal patient, you would see only a big blob of MM. If you have somebody with an MI, a heart condition, you're going to see a blob at MM and a blob at MB. If you see somebody with a brain tumor, you might have MM with a blob at BB, okay, because it's coming from your brain. And here's an example of an isoenzyme. Here's your normal where you have MM, MB, and BB. Now we know that MB greater than 6% is an indication of an acute MI, and we know that all of the instrumentation that we use now does actually measure an MB fraction, correct? So what it does is it measures total CPK, and of that total CPK, it measures which one have these two little MB protein things sticking out, because it does it by an immunoassay. It elevates within 4 to 8 hours, peaks in 12 to 24 hours, returns back to normal in 48 to 72 hours. Normal ranges differ, as we said, for male and females. LD, now LD used to be used much more frequently for acute MI. Its body source, if you look at heart, liver, skeletal muscle, RBCs, this is important too, because what if you have a hemolyzed sample? Because inside of that red cell you have LD enzyme, so you can skew your results. I heard knocking. Now, LD can be separated into 5 major fractions. LD1 is the fastest, followed by 5, which is the slowest. So in healthy people, the major isoenzyme is 2, followed by 1, 3, 4, and 5. So you will get the LD flip when LD1 exceeds the concentration of LD2. And that was one of the questions that we have. I think as certification exams go on, we're probably going to see this question being phased out or asked in a different way. Because if you have a hemolyzed sample, what are you going to see? Higher levels of LD1 from hemolysis, not because of an MI. All right. There you have hemolyzed samples have elevated LD1. Elevated LD3 are associated with lung, pulmonary. 4 and 5 go with liver. And some of the things with analyzing, many times LD samples are stored at room temperature and are not, should not be hemolyzed. AST is usually, we think of cardiac or liver and skeletal. We used to use this in cardiac enzymes, not used anymore, but you can use it. It does elevate after an MI within 6 to 8 hours. We now use it for liver, because you can see it will elevate about 100 times in viral hepatitis. It will go up about 4 times in cirrhosis. So we like to think of now AST as a liver enzyme. ALT is also a liver enzyme. We know ALT is measured at the blood banks. Remember, our donors are screened using ALT to determine if there's any elevations at all. Any elevations can mean that this patient may have had some liver inflammation. So ALT is probably more significant than AST in regards to liver. ALP, liver lives, bone burns. Remember that with alkaline phosphatase. If you look at, also we look at this for bone and liver. There's a few other applications. But what we did was we heated up the alkaline phosphatase to see how much was left. And what we got was, if you get heat inactivation, that means that it was from the bone. So heat it up 10 minutes at 56 degrees, and if you have less than 20% of what was previous, then it's bone. So now you can look at the ALP and look at other enzymes and understand where it came from. Now remember, if you have a normal AST or ALT and an elevated ALP, chances are, where does that ALP come from? Nobody's listening. All right. If you have normal ALT, normal AST, elevated ALP. So bone, think about it. Look at the other two enzymes. They're normal. And then the ALP is elevated. Bone. Now, if you had an elevated AST, elevated ALT, elevated ALP, where is it coming from? Liver. Look at the company it's keeping and by what knowledge you know, okay? If you have an elevated ALP with a normal ALT and AST, okay, that's bone. So it's, you don't have to heat it up to see that. Now, where is ALP normally elevated and it's normal for this population group? Children, because children are growing. So it's about 3 times as high in little kids than it is in adults. In circulating in women, yeah. And let me tell you, women who are pregnant have very different types of chemistries. You really don't, you don't even want to look at them unless you have somebody that is looking for a specific reason, really, because it's almost like geriatric type of blood work because they're also very different as they get older. Question? Okay, confusion about labile or stabile, right? When something is labile, it means that it is sensitive. It will go away. All right, so if it's heat labile, it means that it's going to dissolve in the heat. It's going to go away. Heat stabile or stable means it's going to stick with the heat. It's not going to go away even after you heat it. Okay? Now, acid phosphatase is not measured as much anymore, but it is good to look at a couple of specific things. Acid phosphatase comes from the prostate. It is a very rich source, so you can look for prostatic carcinoma, but we know as those levels elevate that chances are you're talking about a metastasis when they get too high. All right. Now, we can also look at this for forensic reasons. So you can do an acid phosphatase level for forensic purposes. Make sure that you separate the sample immediately and acidify it. That might be a question about sample preparation for acid phosphatase. GGT, a better liver enzyme, so we look at GGT almost specifically for liver. So remember, throw that into the mix that I just told you. That even makes that whole picture more significant, if it's elevated or not. So coupled with ALP, etc. Amylase, what do we think of amylase for? Pancreas. What other enzyme goes along with amylase? Lipase. So amylase and lipase go hand in hand. When you have an elevation of amylase, usually it is from the pancreas. You're talking somebody with pancreatitis. All right. Pseudocholinesterase, we use this for insecticide poisoning. Let's go right to the picture that shows the testing. You're going to test the pseudocholinesterase. If it is low, the activity will decline when you are exposed to these phosphoinsecticides. So if you test somebody, say if you go work over in the middle of the state where they're doing a lot of spraying on the citrus, you will probably do this test routinely. Troponin, we talked about earlier. Troponin is the better cardiac marker. It will stay elevated. It goes up quick, 3 to 4 hours. It will stay elevated from 5 to 9 days. So you can actually see what point this person may have already come in quickly. He may have waited several days, and it will still be elevated, so you can see if indeed he did have an MI. Myoglobin, we talked about, 2 rises within 2 hours. A negative test is more significant as a rule out. Many labs have dropped this now because it's not as significant. BNP, or beta-natriuretic peptide, that is used for detection of congestive heart failure. And this is a wave test. Did you guys do that? Because you don't have to prepare the sample. All you do is take it in the little pipette, put it on the little cassette, put it in the instrument, and push go. How many of you have done a BNP test? Yeah. If you're in chemistry, Heather's done it. You guys, it's just a little machine. Yes, certain doctors do it because they want to know whether their patient is in congestive heart failure. Now, what BNP is, it acts on the glomerulus. It's actually secreted from the heart, one of the ventricles, and I can't remember if it's left or right ventricle. And what it does is it tries to get your kidneys to excrete more fluids, because congestive heart failure, you have your heart becomes congested and it doesn't push the blood flow as adequately. Question? A pro-BNP and B, I don't know. I don't know if it is the pro-BNP is maybe a precursor. It might be more sensitive, but the outcome, I think, is the same. And I don't know, Cynthia. Yeah. And I think it's just what they're testing. One of them, right, one of them is put on the automated instrument, right? On the instrument, but they're still doing BNP on the benchtop? Okay. All right. So is that, Heather, the Pro BNP? Oh, well, I could see it could be cheaper to do, and it's going to give you the same number. Each one of those little cassettes, it's about 20 bucks. And yeah. Yes, for one of those. So it is a very expensive test. So if you can automate it, you know, you can do many more at a cheaper price. And yeah. All right, and Ischemic-Modified Albumin, I don't think anybody's doing this yet. Let's skip over that. We know high sensitive C-reactive protein can be done to see if you have inflammatory process going on in your coronary arteries. This is not the same as a C-reactive protein that you do on the little test for immunology and serology. Homocysteine also has been associated with increased risk of coronary artery disease. All right. Do we need to take a little break, or should we go through? All right, let's take a break.